This is a trial in patients with metastatic breast cancer. These patients haven't been treated with any kind of endocrine agent before. They're all hormone receptor positive. And the trial compared Fulvestrant at 500 milligram monthly dose with anastrozole to see if we could improve time to progression. We found that we could replicate an earlier phase 2 trial that Fulvestrant produced more disease control over time than anastrozole. So this is the phase 3 trial, the FALCON trial. Confirmed was 2 different doses of Fulvestrant. And so this is anastrozole, the standard of care now for first-line metastatic treatment, versus Fulvestrant, hopefully producing an improvement over anastrozole. It improved time to progression by a modest amount of about 3 months for median time to progression, although there were interesting subset analyses that suggested that patients, particularly with non-visceral metastatic disease, so they would be patients with inoperable local disease, bone-only disease, or perhaps lymph node disease, there was a particularly marked difference between the 2 drugs, where Fulvestrant was getting patients beyond 22 months of median progression-free survival, and we thought that was clinically meaningful improvement over anastrozole that was getting to 13 to 14 months. Well, it's interesting because the standard of care is not really well established for patients with de novo metastatic disease. The object for these patients is to keep the disease under control with low toxicity agents for as long as possible. In other words, avoiding chemotherapy and other more toxic agents. And so it's good to see a drug can achieve better disease control than a standard in that setting. This is going to be a registration trial, so this we'll see what the regulatory agencies do with it. In terms of further confirmatory trials, I think one of the things we're struggling right now with is endocrine monotherapy, which patients should get endocrine monotherapy as opposed to patients who should receive an endocrine drug with a CDK4/6 inhibitor. Obviously, endocrine monotherapy is a simpler treatment, requires less monitoring. And for those patients who are in response, they obviously have an excellent quality of life and very simple follow-up program. But some patients clearly need a second drug, and so working out who needs which approach will be a big topic of debate over the next few months, I suspect.